Great, good afternoon. Making sure I've got all the right buttons for where to advance slides. It's the after lunch, know the technical thing. I found the device. Okay. Oh, good. So I was asked to talk about the workforce for community-based care and kind of who's in and who's out. And I think the short answer of who's in is almost everybody. It's a huge workforce that we can discuss. So who is providing care in the community? One of the largest numbers of paid folks, and I'm going to provide some data on these numbers, are the personal care aide and a home health aide workforce, which is a very large and substantial and important part of community-based care for people with serious illness. We also have community health workers and navigators who are playing a growing role. Home health nurses are engaged deeply in the community in agencies and in various other related roles. Community paramedics, who I will talk about briefly, who are emerging in various states, but not every state has authorization for paramedics to go beyond a very traditional kind of treat and take to the emergency department type of approach. But there are some exemplars where paramedics are authorized to do everything from make decisions about whether the person should be transported to urgent care, a sobering center, or some other kind of setting for care. And also in some communities, the paramedics do post-discharge visits to people to help provide some surveillance and some oversight for them, especially when home health services might be limited. Social workers and licensed clinical social workers as a specific subset of that also play really important roles in the community. Of course, the report that the National Academies released on integrating social care, I think, highlights the broad work that social work is involved in very, very well. Spiritual care providers, as were discussed in the first panel today, are essential throughout care in the community. Peer providers who often are focused on behavioral health needs of their clients and the people that they work with. And in some states like Georgia, peer providers that began in the behavioral health space now can obtain kind of a whole person care peer provider certification. And then last but absolutely not least are the family caregivers. That it's very important that when we think about the workforce of who's providing care in the community, we recognize that the lion's share of care is really happening from family members and often friends, a whole panoply of informal caregivers who are doing high skill, high stress, high need work to support people with serious illness, but who often kind of fall off the radar when we talk about integration, coordination, sharing information, and so on. And there are the other professions that we all are so familiar with when people talk about these things: physicians, nurses, pharmacists, physical therapists. Those professions all naturally come up in conversations. What I like to do sometimes is flip it over and talk about the relative size of these different workforces and help people remember that the people who are in the non-licensed healthcare fields are incredibly important. So to give some perspective on those numbers, how many people are holding these kinds of jobs? So this is just people by occupational designation, which has various problems. The Bureau of Labor Statistics data, we could spend a whole workshop complaining about the BLS data. The fact is they do a very, very good job with their data, but people are classified by their occupation and then by their industry. And if sometimes the occupation doesn't quite line up. Like if you are a leading manager in a pharmaceutical company and your background is nursing, we're not going to see you as a registered nurse. If you are working as a registered nurse through a temporary agency, we see you as working in the temporary services industry, not in the healthcare industry. Personal care aides are a bit of a pet peeve, I think, for many of us, because the personal care aides in the data don't even live in the healthcare professions. They're in the same category as hairdressers. Seriously, they're in the 39 occupational category where you find personal trainers, hairdressers, and other personal services workers, as opposed to where I would kind of think they belong, sitting right there with home health aides. So whenever the standard occupation classification comes up again, that's something that you can write in about. And, We always mention that to Michelle Washko as well. So, it's a known problem. So what do the employment numbers look like? Well, so registered nurses are the largest single occupation in the United States. And the Future of Nursing 2030 committee that is now underway is continuing to build on the prior work that has been done by the national academies in thinking about how registered nurses contribute to our healthcare system. You can see, a lot of what people talk about with nurses is focused on their roles in hospitals and their growing roles in ambulatory care. But if you look at the nursing, residential, and home health bar, that little orange bar, there's a lot of them in that space. There are also a lot of them that are in the all other settings, which includes a lot of the kinds of care that we're talking about around serious illness, where they don't really fit neatly into these other buckets. But then if you took personal care aides and home health aides and added them together as occupations, they surpass registered nurses. Those occupations have a lot of overlap in between them, and I think there probably is a certain amount of randomness to how they get categorized when occupational surveys are being done. So in sum total, it is just about 3 million people as well. And their settings vary markedly. Personal care aides, a lot of them are employed in other health and social services programs, nursing, residential, home health, and ambulatory care. But that relatively large chunk that are in other are people who are directly employed by households. And they can be very easy to miss in the data because they're not being employed in the healthcare industry, but they certainly are providing what I would think of as healthcare services. Home health aides are more typically employed in institutional settings and organizational settings, providing home health type services through agencies and as adjuncts of ambulatory care organizations and such. But let's not forget counselors. All the different job titles surrounding counseling surpass the number of physicians in the United States. Social workers are nearly the same numbers as physicians in the U.S., and then you've got all the other professions. Now, notice that tiny, tiny little bar for community health workers. We think that the data woefully undermeasures them. We know it's a growing profession. We know that there are large numbers of people engaged in various navigation and other roles. And right now, the occupational surveys, we think, are doing a terrible job of capturing them. So there have been national recommendations put forward to try to solve that problem. Hopefully, the next time the occupational classifications are revised, there'll be an opportunity. So I want to hone in on the aides because those are the biggest workforce. On their current and projected aide employment, the left pair of bars is home health aides and the right pair of bars is the personal care aides. And of those pairs, the left one is the 2016 employment and the right one is the 2026 projected employment from the Bureau of Labor Statistics. And as you can see from that, the amount of job growth is really just incredible. It's going to be easily over 1 million new jobs over a 10-year period in these home health and personal care aide types of positions. And the settings are going to be pretty broad, ranging from services for people who have disabilities and the elderly, through home health care, through even government agencies, residential care, and so on. And so we need to be, I think, particularly attentive to this workforce as being one of the linchpins in what's happening in the community. The training of this broad kind of community-based and home-based workforce tends to be many of whom are unlicensed. So the professions that are licensed here, or that you would kind of think as I'm trying to remember what I had a logic for my color coding. Now I'm not remembering it. In general, I remember. So the ones that are green basically are not licensed positions and where the education is largely short-term on-the-job training. And so those individuals are educated and prepared for their work through a variety of different strategies that include a lot of hands-on time and experiential opportunities. The trade-off is for those, as I'll show you in a few minutes, is with the short-term on-the-job training, the workers do not have the opportunity to invest in their skill development in the degree that might be ideal. And the employers very easily, and society at large, easily writes them off as untrained people, unskilled, untrained people. Now, if you've ever watched a good community health worker or home care aide in their job, that moniker of unskilled is the most inappropriate moniker you could ever hear. So I worry that the classification of them as kind of unskilled or short-term and only on the job really understates their knowledge and what they bring to the table. Registered nurses do not really have training per se, but they're at the associate degree level. You also have in the kind of not having kind of light amount of on-the-job training, EMTs and paramedics, clergy, but these are also roles where there is a good level of education involved and licensing for some of these professions. You've got, various levels of licensing, internship, and college-level education for almost every other occupation that I mentioned in the healthcare space, which creates a bifurcation in the workplace world. Another way to look at the education distribution of healthcare workers is by the settings that they're in. People who work in long-term care, 62% of them have a high school education or less. So the vast majority of people, by the numbers, who are working and providing long-term care services, and that includes home health, are not high school educated. And note that these data, since this is by industry, do not account for people who are directly employed by households, because that's a separate industry classification. So you've got a lot of people who work in providing care for those with serious illness who do not have a post-secondary degree, but are performing skills and working with teams where everybody else does. And that can make it very challenging for them. We've got a range of job titles that add confusion. This is adapted from a slide that actually some folks at HRSA had developed originally, and we've kind of added onto it over the years. So these are all the job titles that we have seen that I view as kind of flavors of the community health worker theme. And then you wonder why we can't find them in standardized data sets. You've got navigators, coordinators, promotoras. You've got There's actually a whole family here that I don't think I have even on this slide related to oral health. In Alaska, there are primary dental health aides that are essentially a community health worker flavor that specializes in oral health. And their model of care and training was built off of the community health aide program of Alaska, which is a community health worker program. So you've got all of these different job classifications, which I think adds confusion and also provides a sense of a lack of cohesion. On the plus side, this also means that there's a lot of experimentation and learning that we are doing about how community health worker type roles can best serve the populations that they work with and the needs of their communities, which is kind of the point of community health workers. Another piece of confusion is that the training requirements across these different occupations can vary even among jobs that sound like they should be essentially the same job and even within a single state. So we did some analysis in California where for the positions that you would think of as personal care and home care aides and home health aides, we've got kind of 5 different classifications you find in the regulatory structures, ranging from home health aides who are generally working for home health agency with Medicare services. And there is some training formally required by that, and they have a certification for California from our Department of Public Health. Then our Home Care Services Bureau, which is not in the Department of Public Health, go figure, they have a kind of a registration program for home care aides. And if you are employed by a home care organization, you have to be registered as a worker. And then there are people who are registered who might be directly hired by a household. But households might say, I prefer to hire somebody who's registered because they've had a background check and met those basic requirements of 5 hours of training, which is not a lot. Then you get the unregistered home care aides, which, is you posted a job on Craigslist and you found somebody that you liked and you hired them. And their skills and the vetting vary entirely depending on what the household wants to do. And then California has a consumer-directed program. So this is the in-home services provider. And those folks may or may not be registered. So talk about confusion. Moving forward. So training is problematic in that there's inadequate training, there's no federal standards for training, and there's variation even across just looking at state Medicaid programs where 10 states in 2014 had no training requirements, 19 had uniform requirements. So you've got that variation. And CMS has developed core competencies, but there's little research on the impact of training. Payment is all over the place. Medicare, Medicaid, delivery organizations, out-of-pocket for individuals. We don't have a rational or organized payment structure in this country. And home care has specific financing challenges around people paying privately. There being multiple programs in Medicaid just to drive Medicaid administrators nuts. And the self-direction option varies across states. There's very little research about the impact of self-direction. We think it's important, but we don't have the data on that. And this leads to inconsistency and confusion for this workforce. These occupations are very racially and ethnically diverse, though, and I think in that standpoint really lays the ground for their potential to help lay the basis for culturally competent care and culturally care that has appropriate degrees of cultural humility. But it also adds a challenge in communications across teams. The workforce is also very economically vulnerable. So the bar that I put the percentages on is people who are working part-time in long-term care, and then the light pink is people working full-time in long-term care. And the light turquoise is people with high school or less education, which would be a large share of the long-term care workforce. So if you look at their earnings, 18% of the part-time long-term care workforce is earning less than $15 an hour. 20% are at or below the poverty level. Of people with high school or less education, it's 15% below the poverty level. You've got high rates of people without health insurance themselves. You've got an incredibly high share receiving earned income tax credit, Medicaid enroll, and receiving food stamp benefits. So we've got a lot of economic vulnerability in this workforce. Turnover is a big issue, 67%, and it's associated with poor client outcomes. There's a lot of research on why they leave, including supervision, underappreciation, safety issues, and instability of the work. Quite frankly, their career ladders are often better working in fast food where they could become a shift manager. And so that is a problem. So there are opportunities for change that have been identified and put forward in a variety of reports. I'm running over time, so I'm going to kind of skip over that, and we can discuss that more later because I want to make sure everybody else has an opportunity to present. But hopefully that doesn't depress you too much, because I think this workforce is so important and so unappreciated that I think there's huge opportunities to move forward with it, and we've got plenty of skill and talent and passion to draw from in this workforce. So thank you.